Hello, can you share your name, pronouns, and an introduction about yourself?
Hi, I'm Art Caplan, and I'm the director of the Division of Medical Ethics at the NYU Grossman School of Medicine, where I've been about 11 years.
Oh, thank you. And as a leading figure in bioethics, can you discuss your journey through your education and what inspired you to accomplish the work that you've done and can you continue to do so?
Well, when I was a little kid, I had polio, and sadly, it left me disabled. But when I was in the hospital, even as a little kid of 7, I saw a lot of things going on that I didn't really understand. Why couldn't my parents visit longer? Why couldn't my dog come in and see me? They managed to get my sister in there, but they didn't manage to get my dog in there. Um, and they managed to get my homework in there too, I might add. So questions came up. They didn't tell us the truth about when somebody died. They weren't really open with us about what was going to happen in terms of our future fate, and that they also didn't really have any cures or treatments for polio. They were giving us heat packs, but they had nothing that would be curative, but they didn't say that. So I think I had an early introduction to medical ethics that way. Later, when I got my PhD at Columbia, I began to do some work at the medical center in teaching medical ethics. Saw a lot of interesting cases there involving early in vitro fertilization, who would get kidney dialysis when we didn't have many machines. All of that inspired me to try to think of ways that maybe you can empower or help patients. And that's sort of been a driving factor in my career, trying not only to do academic work, but try to move it out to the world, try to do communications through the media to the public so they can make better choices.
Thank you. And as the founder of the Center for Bioethics and the Department of Medical Ethics at the University of Pennsylvania Pullman, can you speak to the process of establishing such institutions and the visions that were actualized through their creation?
So I actually set up three programs, one at the University of Minnesota,
Mhm.
one at the University of Pennsylvania, and now here at NYU. And I'm strongly a believer that if you're going to do bioethics, meaning ethics in medicine and the life sciences, or medical ethics, which really refers just to medicine and nursing, but if you're going to do the area, you've got to have the ability to bring in faculty, give them careers, let them get promoted, let them become established. And so that was my goal with the creation of all three programs. The first one was the hardest because there weren't many other departments, divisions when I was in Minnesota around the country. There are a few, but not many. So we wound up being a program in medical ethics closely affiliated with the Department of Surgery because of my interest in transplantation.
Mhm.
So there was us and I don't know 150 surgeons. At NYU, we're in the program called Population Health, which is like public health, a little better fit in some ways. And that allows us to do studies, surveys, interviews using qualitative techniques because that's what the rest of the people in the department do outside our division. So I think having institutional homes is a real need if you're going to have faculty security and somewhat the freedom to raise hard questions sometimes. Not everybody is excited to hear every question that ethics raises.
Mhm. Absolutely. And as you mentioned just a little bit ago about your involvement in organ donation, in regards to your extensive research in this subfield, what findings of yours do you feel are most laying the groundwork for those important conversations? Or have there been any setbacks in organ donation that you are currently speaking to?
Well, long ago, way back in the 80s, I was puzzled why we weren't doing more transplants when we didn't have enough kidney dialysis. There weren't really doing much in the way of heart or lung or liver transplants, but kidneys were getting done, and we just didn't have enough donors. So I asked around and eventually established that one reason we didn't have enough donors is we weren't asking for donors. So one of the first laws I got behind and worked with the New York State Legislature on, which was its own experience to tell you about another day, is to push through a law that required when someone died that the family or guardian be asked about organ donation. That became required request. That became the law everywhere. It's part of hospital accreditation. All OPOs rely on it in many ways. And it did give a boost to organ supply. But at that time, even then, not enough to meet the demand, but the demand has only grown. I also was around for the creation of UNOS, worked with Al Gore in trying to set up a system that would allocate organs in a systematic way, not just sending them to your buddies or your friends if you couldn't use them. And that system became sort of the computer registry that we now use to distribute organs nationally. And I think that's been a good thing, although I've been a critic of some of the ways organs have been distributed over the years. And for example, I'm still not a big fan of allowing rich people to register in more than one area to
Mhm.
become eligible for organ donation, multiple listing it's called. And just seems to me to be unjust, but I've never been able to get it fixed. Other issues, got interested early on in arguments about whether or not we should try face transplants and what are called vascular composite allografts, meaning external organs and tissues, arms, faces. And at first was opposed, but sort of watched some of the work, met people who needed the procedure and got involved there, ultimately being persuaded that it was legitimate to try it, and came up with some of the first guidelines for doing VCA transplants, in that case, the face. And most recently came up with a model to try and study some forms of transplant, like animal transplants on the newly dead. So I've been thinking for a long time that research on people who would volunteer their bodies to be studied after their death for a period of time would be the safest way to see whether, say, things like pig heart or pig kidney transplants were ready to try in humans.
Wow, that is incredible. As you mentioned with the multiple listings, when it comes to inequities in organ donation, what does it look like being involved with policy work alongside your research, and how is it received by people who might have not studied STEM fields in particular?
Well, the biggest challenge in America for equity is not discriminating against people who are, let's say, older, or people who may be here without full papers. It's still the inequity in being able to pay for a transplant. So way back in 1972, kidney transplant and dialysis was included as a Medicare benefit, but it turned out to be so expensive that they never replicated that again. So for hearts and livers and lungs and faces and hands, if you don't have insurance, you're not going to get access. And some insurance programs won't pay, some pay not enough. The coverage for the drugs you need to take, the immunosuppressive drugs post-transplant, usually runs out after a couple of years. Well, that's not very good. You're going to lose the organ for many people that can't pay. So finding ways to cover the costs of transplant still remains a very challenging issue. Transplants look expensive, but if they buy you a lifetime of function, they're kind of worth it. We also don't discriminate in who we take organs from. We'll accept donations from rich people and poor people, but if we only give them back to the rich and the middle class because they have the insurance, then we hurt ourselves in getting donors, because some are going to say, well, if I can't get an organ, then am I going to give an organ?
Mm-hmm. And recently, ODAC had a couple conversations about supporting live donors who might be from lower or middle class income households who, as they give their live donation, might lose a bit of income during that process, and what legislation might look like to support them. Is that also something of interest to you, and do you have any thoughts regarding it?
Yeah, I've weighed in support of, and long argued that we should have a situation where people don't lose money or income if they're willing to be a kidney donor, or for that matter, a bone marrow donor, things that you can do when you're alive. And I don't agree with those who argue that we should permit sales. I think sales of organs is going to unleash a whole different debate. You're going to get religious opposition. from people who don't believe you can sell your body because you don't own it. God does. You don't have to accept that or reject it. It's just going to trigger some vocal opposition that will damage the whole field. It's also hard to run a market system for kidneys, paying the donors next to a system where you can't do that for livers and hearts. So you get into this inequitable management problem. But I do believe that we should give health insurance, life insurance, any expenses, any sort of costs that a person who donates, that should be covered. And New York State moved in that direction, and I think that's good. I've written op-eds in support of that. So I think we don't want to make altruists worse off.
Mm-hmm.
But at the same time, it's tricky to pay people for their parts. You get into situations where you're still asking, are they getting coerced? Are
Mm-hmm.
they doing it because someone's threatening them because they have a gambling debt and they say, you better sell your kidney because you owe us money? Or situations where people are going to look at, direct payment for organs and say, well, I'm not going to tell you the truth about my health status. I'll cover up my HIV or my hepatitis, or I'm just not going to admit to you that my organs may not be suitable or best for transplant. So yes, reimburse costs. My position is no, not yet for markets.
Okay, thank you. And outside of conversations about benefits or possible challenges with different policies regarding donation, have there been any clear misconceptions that you've run across? And in what ways are you able to dispel them?
The biggest misconception is still out there, and that is if I indicate I want to be an organ donor at motor vehicles or register in a state's computer system, that I'm not going to get treated aggressively if I'm sick. They're going to let me go and provide my organs to a rich person or a celebrity or someone who the doctors and society think is more worthwhile. And we've set up a system for the past 50 years that basically says the people who treat you and try to keep you alive in the hospital have no incentive and no responsibility to worry about organ donation. They're just there to treat you. And when they think they can't do anything further, or your heart or brain stop working, then you're dead. Only then do we get to the issue of now what? Autopsy, organ donation, funeral, whatever. So we've tried to build a wall between those who treat people and those who ask about organ donation. Still, the public often doesn't know that, or they don't believe that, or they don't trust that. So that's probably the biggest obstacle out there, is the fear that if I identify as an organ donor, I'm going to suffer poor medical care.
That's often what you have mentioned is often what we bring up to the students that we get to speak to, often high school students as they're getting ready to receive their driver's license. So, what thoughts or advice would you be giving to young adults who are considering possibly registering as an organ donor?
Well, to me, there's two real things to think about. Younger people are likely to have the ability to save many lives through multiple donations of organs because their health is good. I can sign up to be an organ donor, but it's unlikely that people are going to want many of my organs. I'm too old and there's too much wear and tear on them. So there's a special opportunity that a young person has, not just to save one life, but to save many lives. I also think they should think hard about what their religious traditions expect of them, because the major religions all support organ donation vociferously. They think it's a real good thing to do. It's a real benefit to the community. It's not something that they think interferes with burial or going on to the hereafter or resurrection or anything like that. So it's seen by many cultures and many religious traditions as absolutely a good. So if it's a good thing to do and you can save a lot of lives, I think it's something you really have to think hard about why you wouldn't do it.
Mm-hmm. Yes, absolutely. Thank you. And with the evolving landscape of medicine and technology, in what novel directions do you see bioethics moving in today? And are there any directions that especially excite you?
Well, in the transplant field, I think we're going to see more and more use of cell repair, stem cells, rather than transplanting a whole heart. If someone had a heart attack, repair the damaged part of the heart by growing cells in there. I know there's a lot of interest right now in animals, particularly pigs for transplant. We'll see. I don't think that's the long-term answer, though. I actually think mechanical organs will be the long-term answer. It's just still having to involve genetically engineered animals, using a lot of immunosuppression. It's not the most elegant solution. It's what you do when you don't have any other options. But down the road, I think we'll see more mechanical hearts, mechanical lungs able to be put into people to keep them going, or regrowing, as I said, the damaged parts of some of those things. Future of bioethics, well, it's certainly got a big future in thinking about artificial intelligence and how that's going to be used. Every day I see more and more things online saying we're going to run a doctor online or a doc in a box, and you can get your care by just talking to this robot chat GPT doctor. And I keep thinking it's too early. None of this is yet certified. Nobody's regulating what the AI doc says, maybe to augment medical care right now, but not replace it. But in any event, I think that's going to become a big issue about how far we can go with AI in terms of the provision of healthcare. Climate causes all kinds of health problems for us. So we've got to pay attention to climate change. Bioethics hasn't done that historically, but if we live closer to animals, or because of climate change, more and more insects and pests get closer to us, that raises obvious health worries. We've got dengue and Zika starting to spread into the Americas where it wasn't before. So we've got to do something to slow down change in the climate if it's going to really affect our health. I think one other area is interesting enough, vaccines, even though they were controversial and people didn't know always what to make of them during COVID, there are some very exciting new vaccines appearing. Malaria vaccine just being introduced in Africa. Malaria is the biggest public health problem out there. If you could get a vaccine against it, it would just save millions of lives. We're also developing a herpes vaccine. There are plans underway probably to get vaccines going for syphilis. So I think even though vaccination scares some people, to put it one way, I think it's got a future in preventing a lot of diseases, dengue, Zika, many diseases that really take a toll.
Mm-hmm. But it is incredibly exciting to see how the public health initiatives are going to be rolling out. So thank you so much for mentioning them. And are there any projects that you're currently working on that you'd like to speak to?
Well, we have projects at NYU underway on vaccines, looking at how to get more accurate information out there, get more public trust. We have a big program running, working group on transplant ethics, which is looking at how to try and increase rates of donation, looking at animal transplants, definitely paying attention to trying to increase equity in the distribution of the organs we do have. Got projects running on aging and longevity. Is it right to try and slow aging or reverse aging using either diet or drugs? And we have a big program going on reproductive ethics. You know, there's a lot of interest these days in freezing eggs, people trying to plan reproduction when it suits their lifespan. But a lot of people don't realize that that technology isn't 100% effective. They hear celebrities saying, I had a baby at 50, and they think, oh, well, then anybody could do that. But that isn't so, particularly when those women who announce that are using donor eggs, surrogate wombs. It's not what necessarily is being portrayed on the media. And yeah, I think those are among the various projects that we're running. They're all working groups of 12 to 15 people, mainly NYU, but sometimes others, sometimes students. And those can all be tracked on our website.
Okay, thank you. That's incredible to hear. And now I just wanted to give you some space if there was anything else you would like to mention or any people or teams you would like to give a shout out to.
Well, I think one thing I can say is there's sometimes this perception that the transplant community is a little bit on the arrogant side, a little bit distant, that they're not open to comment and critique. And I can say throughout my career that's never been true. They don't always do what I advise. That may be wise. Maybe it's bad advice, but they're open to listen. They like to hear. They're willing to consider uh, input. And I think they get a bad rap in terms of also, they're trying to study what they do. They're trying to see what the outcomes are. They're looking for ways to extend the life of people post-transplant, to look for ways that will hopefully reduce the need to take immunosuppressive drugs. That cuts cost and cuts healthcare burden because those drugs are not without their own adverse events. So I'm going to give a shout out to the transplant community. Over my career, as I say, as one of the people who both helps but also criticizes, I found them to be a pretty good audience compared to other parts of healthcare.
Thank you so much for sharing your expertise and your experience. It was such a pleasure getting to hear from you today.
Thank you for having me.